Okay, well, welcome everybody. Thank you for joining the Minnesota Coalition for Family Home Visiting. We are very excited today because we have several people joining us who are implementing some really important policies across the state of Minnesota. And we wanted to share that work with you and give you the opportunity to ask questions of those who are implementing it and try to help inform some of that work. I did want to make sure also that before we have our guests speak, that I share this link here. We have our newsletter that goes out quarterly, and in that quarterly newsletter, there were a number of policy updates that impact family home visiting as well as the families that we serve. I wanted to highlight a couple before we get started, but before we do that, I would be remiss to if we didn't ask you to introduce yourselves. We have a number of people here and a lot to talk about. So what I'm hoping you will do is put down your name, and similar to what Mary Losbaker did as well, and your name, who you're here representing today, and one thing that you hope to learn. And we will watch that chat and make sure we try to address as many questions that you might have for our speakers and or the executive committee on behalf of the coalition. So thank you. And we do have a number of people who have joined us for the first time today. We've been going around the state visiting people locally, so it's exciting to see many of you here for the first time as well. All right, so I did mention I put the chat a link in the chat box, which is will direct you to our latest newsletter. There are a number of policy changes that impact families in the maternal and child health space. And in addition to the 3 policies that we will talk about today, I also just wanted to highlight, in case you hadn't seen it, that there were policy changes in the Department of Labor and Industry providing increased pregnancy protections and lactation support. And I think it's really important that we let the moms and families that you are working with know about these protections. So if you need more information after taking a peek at the newsletter, feel free to circle back. I can send you some links to the Department of Labor and Industry. The exciting piece now is that if you work for somebody that has 15 employees or more at the beginning of the year, these additional protections are in place for you during your pregnancy. And beginning in January, the time that you take to express milk is paid. It has to be paid. And so that is a nice welcome change for moms that we think will have a great benefit for babies as well. So I wanted to highlight that. The other piece I wanted to highlight, 2 more quickly, is the Dignity and Childbirth Act. This is new legislation that also provided some resources to develop a curriculum on implicit bias, and then training will be available for labor and delivery staff. This is an important opportunity to help us address inequities in maternal and child health and birth rates. And I will say, even earlier this week, when I was doing site visits across the state, I heard a home visitor, a supervisor herself, talking about her own experience as a Latina woman when her doctor told her how impressed he was with her English. Yet she was born in the United States, grew up in the United States, and had no idea, didn't take the time to get to know the individual. And it has these types of interactions have huge impacts on people's ability to seek care or desire to seek care. So we're hoping that the Dignity and Childbirth Act will help us move in the right direction in Minnesota. And the final thing I wanted to highlight, it's actually a federal policy. It's the child tax credit. And that is in place. If families have filed their taxes, they will automatically get the tax credit. But we know that we work with many families who haven't applied or submitted taxes, and they are still eligible. And so please click on that link, find out more information, and share with the families that you're working with. We know so many families are in need at this point in time. So with all of that, I will stop. I get excited about policy and how it can help us improve our practice, but we now have the time to talk about practice. And so I'm going to turn it over to Joel, who will introduce our first speakers.
Again, my name is Joel Flanton. I'm with Supporting Hands Nurse Family Partnership, and I'm their executive director. We're excited today to have a couple representatives from the Minnesota Department of Health, Joanne Brandt, who is the Family Health Division Director, and Don Rector, a lot of us know her, is from the Family Home Visiting. She's a section manager. They're going to talk to us about the evidence-based program grant, and among other things, and the changes that were made to include the Evidence-Informed and Promising Practices Act. So they'll touch on that, and I'm sure other areas. In addition to that, they'll also talk about the $4.5 million in one-time funding that we've received over the course of 3 years, and how that will be used to hopefully support some changes. And I'm also thinking they'll seek some input. After this is done, we're gonna give some time for questions and answers for them. So Don and Joanne, I'm going to leave it up to you guys. You guys can start. Thank you.
Take it away, Dawn.
Sure. I was walking on my treadmill if some of you were wondering why I was moving. Good to see those of you that we can, and to see all the names. It's nice to gather virtually, if not in person. And I think mostly what we want today is to really get more input. So I'll explain real briefly. So as you guys may know, the legislation was codified to both the NFP and the evidence-based. And in the codification, they added, they kept the evidence-based, and at least 75% of the funding must go to that. And they also added the language on up to 25% could go to evidence-informed. And there's a pretty clear definition of what that means. And it also a line on promising practices. And I will just say for everyone has different probably perspectives and interactions with that. In the service world, promising practices has a pretty clear definition. You can go to the Child Welfare Gateway, you can go to pretty much any research review. That doesn't mean that those definitions might be your definitions, but we just want you to know that there are, just because we say promising practices, we recognize that not everyone's going to have the same definition. And right now, the promising practices doesn't have that defined. So I think that'll be part of our clarifying journey is what does that mean? The evidence-informed we did put in a more clear definition of what that meant. And again, it says up to 25%. So we also view this as sort of a journey. It doesn't mean that we're all of a sudden going to split the funding and say, well, 75-25. I think we're trying to understand what this would mean. And as you know, most of the current funding is going out to evidence-based programs, many of which are successful despite this little COVID deviation that we've had the last 18 months or so. So I think we're also trying to understand as a department, how are we going to rearrange and shift, and what are we going to do sort of in this, pilot temporary phase up part where we also have some of this extra money, and we're always looking long term. It may not feel that way to all of you, but our goal is to build stable programs, and we know that home visiting programs take about 3 years in the normal world to get to stability. And so, we're always looking at that kind of trajectory of like, okay, what do we want like 5 years from now, and how can we build towards that? How can we put the money out in place to get to that goal? As Laura said, there is this one-time, the 1.5 million that is from the ARP funding that is added into our budget. I think right now our plans are to just put that into the regular distribution. I shared this with the leadership team, and we're all in this situation, but MDH has reassigned the majority of staff over the last 18 months, and we've had a lot of reassign them to COVID, and we're just sort of depleted. We should have a staff of about 22. We have a staff of 12. We can't. It's challenging for us to hire right now. COVID is taking precedence until that is more under control. So I think it's just a reality check of like, okay, what can we do? So for those of you who know me, I'm not short of ideas. I have lots of ideas of what we could do and cool innovations. And I think we're going to have to temper my ideas and the great ideas that the community might have with just like, what can we realistically accomplish? Joan, I'm just going to let you I don't know if you have anything you want to add to that sentiment.
Oh, yeah, that's exactly right. And we're 19 months now into COVID, and it has impacted our ability pretty significantly at MDH to get things done in a timely fashion.
Yeah. So again, we're not complaining. You guys are all on the front lines. Certainly you have your own stories to tell, and more directly that you're interacting with the families that are really impacted. So I just want to make sure no one's like, oh, the state got on and just complained. It's just a realistic view. So the other thing I want to say, and I said, Laura, so I needed a new water heater last week. And so just so you know, the city state department or the city inspector is coming at 10, and I need to let them in. So if I have to step off, I will still have my headset on, but I just want to know that I'm not being rude. I just have to get my new water heater inspected. So the city says it's okay. So anyway, sorry about that. So I think what we want to do is really, I'd rather use most of this time to get questions and thoughts from this group of how when you hear, hey, this new legislation passed, home visiting has more flexibility in how they can put out the money. And my guess is most of you are looking at it from an internal point of view. What would my agency do? What would we apply for? And that's a normal response, and we want you to be doing that, right? What of the families we interact with would that serve? I think it's just good for you to recognize our perspective. So RFPs, there's certainly not a lot of fun to write on the applicant end. I don't want to say that we don't like them, but they're not. What's not fun is it's never fun telling someone that they wrote a great application, they had a great idea, but you can't fund them. That's no fun. No one likes doing that. So what we want to do is I have learned over the years of being here at MDH is let's set that RFP up for clarity and for success. And if you can set the boundaries up ahead of time so people have expectations of like, oh, I should only apply for these kind of programs. I should make sure I have this characteristic in place. I should only apply for this much money. I should make sure that my services, like one of the things we've done is we've had a cap of services should cost no more than $6,500 a year per family. So we try and set some of those rules up in place so that the RFP process isn't a surprise, or isn't that we can minimize the disappointment. And I've seen a lot of it, not so much maybe with home visiting, but I was in SHIP, and so I've seen the tobacco. They've done multiple things where they've tried to open it up. They've tried, lots of different ways to get creativity. And in the end, there are still many applicants who they turn down. And then applicants are like, well, why didn't we get funded? And they funded a bunch of stupid programs. And, and I've seen the community health solutions have to go through that. So I think what we want to know is, or want you to know is, we have a best intent of like, let's try and write the best RFP to get to the agencies where they can write it, so that it's not like, well, they had a super grant writer and that's why they got it. We want actually to reflect the programs and services they're going to provide to the families that need those services. And it's a struggle sometimes of figuring out how you do that. So I just want to put forward this picture. I was trying to think of how to have this discussion. I want you to imagine we're going to put out, $3 million a year for evidence informed and promising. And I'm not saying that's what it will be, but let's just say that's what it was going to be, because we have not only some of the ARP funding, we have underspending from grantees. So we probably could do that. We could say for the next 2 or 3 years, we're going to put out grant agreements, an application where people can apply. So, and 3 million sounds great, but it is 3 million, and so it's not 30 million. I want you to anticipate that pretty much most of the counties, probably half the tribes, and I would guess somewhere between 20 and 30 nonprofits are going to apply for that $3 million. So in the end, we'll probably have 100 applicants. Imagine each of them wanted to hire 2 staff. At minimum, that's probably going to be, and stuff that, at least $200,000. We're already over the 3 million. What, if you guys were advising us and you're thinking of the program you're thinking about applying for, much less the program that could get funded and you're like, I wish they hadn't funded that. They should have funded my program. I think our question are, what are the programs that you say, they funded the right programs. They are addressing these core characteristics. Here, this is what we really value. And then the other end of the question is, what could we fund that you would be like, they totally did not fund the right thing. I can't believe they funded that. Where are those boundaries, right? Where do we say, well, that's a great program, but not for this funding? And so I think I'm going to keep it kind of simple. We do anticipate this to be very competitive. And so I think it's just, I could be wrong. Maybe we'll get 2 applications and we'll, each will get a lot of money, but we're anticipating this to be very competitive, that most local public health departments will take their traditional home visiting and convert it. We know many want to go to universal home visiting. We know lots of nonprofits have ideas about the families they're serving and could create more of a home visiting or, adapt other home visiting programs. So again, the question is, what would be the characteristics of something that would get funded? You'd be like, well, it should have to have this. It should have to have this. And where would be the boundaries of something if we did fund it? You'd be like, that doesn't sound right. That seems out of scope. And any other questions you have?
Joel, do you want to lead the Q&A or do you want me to go ahead and do that?
You could do that.
Okay. So what I would ask is either you can unmute yourself and ask the question or raise your hand and I'll try to call on you. And I'm happy to lead us off with a couple of suggestions that we've been talking about because we've been working on this for 5 years. So when we have been talking about this over the 5 years through the Home Visiting Coalition, and really this will just tee it up because it's maybe not concrete. It's thinking about the populations that we're not serving or that we're challenged to serve through our evidence-based programs. And we have some guests with us today as well and partners with us today who know a lot about this, which will be the next topic. But working with women who are in state prison or in county jails is an important population that we've been talking about through the Home Visiting Coalition in partnership with people. I know that there are people going in and doing elements of it and trying to do an evidence-informed or promising practice program. So this may be a great opportunity for us to think about it. And I see Dr. Schleifer is already with us, and I'm not sure if Safi is with us, but it's some of the, it's a population that we've been talking about. And then the other population that we've been talking about is working with families who are currently living in homeless shelters. So Nidra is with us on our executive team, and currently the model requires them to be in a transitional living space and not in the shelter space. And you think about all the time that families spend in the shelter, if we could also think about working with the community at that time when they're in that space. So those are two populations. And then the third population is really programs that have been led and developed within the BIPOC community. And we know that there's been a lot of work being done in the Black and Indigenous communities across the state. But really, truly, we've heard off and on through the years that many of the tools and assessments we have don't really translate well into different languages. And so they're trying to constantly modify things. So those are the pieces of the some suggestions of where to maybe start that we've been talking about, at least as a coalition. And I know there are many other ideas locally, but just wanted to pass the baton.
And I'm going to try and mostly listen, but and those are great, Laura. The other thing is, I have thoughts coming up is it is really describing the programs in the population. So one, think about, is there an age range in that? Would it be moms and dads? Would it be any child age? At MDH, we have tend to try and focus prenatally or as early in that child's life, up to 3 months to get the family in, because we know that has the biggest impact. But is there a sense of like, oh, the gap is really for 18 months to 3 or 4 year olds, and that's where we should focus this money. So I just want to add on of like all of those, thinking broadly of like, again, so if you found out that I funded X program and it had these characteristics, and you're like, well, what, she was funding 12-year-olds, or hopefully they're not getting pregnant 12-year-olds, but what part would you be like, no, we really should have focused here? Because when we did these discussions initially, when we got the evidence-based money the first time around, everyone, we talked broad, and then everyone said prenatal. We should focus prenatal and early in the 0 to 1. And so that is in part where we put the money out. But now I think that the age would be a key part of like, where do we feel the gaps are, among other things. So I just wanted to prompt that.
I just wanted to also throw out the idea of home visiting through family, friend, and neighbor providers. They're a population that cares for children, but often aren't, they don't get a lot of services. And so it might also be a way to connect with families through them. And then the other population I think about is foster families who care for little children, and I think could also use some help. So those are two populations I think of. And I like the idea of prenatal to maybe age 5 children in the population of being, the population of children you're looking at.
Thanks, Nancy.
I'm sorry, can you hear?
Now we can hear you.
Okay. I don't know. I'm working from home today just till 10, but I agree with you, Nancy, that up to age 5, I think would be very beneficial for most families. We're finding that our referrals are coming in and they're finding kids behind at around 18 months. And so we have to come in and try to implement all these services and get these kids caught up. But some of them are really, really far behind. And so, yeah, I agree. Prenatally is probably you're going to have the best outcomes as far as what it looks like for that child after they've been through the program. But there's also that specific group of kids that aren't caught in that time frame, and around 12 to 18 months we get these referrals where, oh my gosh, this child isn't eating solid foods, this child is still only drinking out of a bottle, they're the mom is feeding the baby Pediasure because they're not gaining weight. We have one that's not walking, talking, and not crawling. So we have those types of cases as well, which are really severe and high risk cases. So if there's somewhere in there where we could kind of meet that need, that would be wonderful.
And Claudia, does everybody know where you are working, what part of the state you're in?
No, I'm sorry, I didn't introduce myself. I'm Claudia Montefiering, and I work at Mille Lacs County Public Health, and I'm the Family Home Visiting Coordinator.
Yep. Thank you. I think what you just said too fits with what we heard from one of your other colleagues, that we're seeing a lot of referrals to Part C as a result of the pandemic, with delays, child developmental delays, and how can we partner with them, with our part, with our educational services and home visitors through Part C.
Yes, yes, I agree.
I have a question, Dawn. Does the funding, is it eligible like for school districts through ECFE and school readiness? Can they also apply for home visiting dollars with this new money? Or maybe they already can, just curious.
Yeah, there are not a lot of restrictions on the funding. It's county governments, tribal nations, or nonprofits. So as long as they fit, as long as the primary applicant was that. I know someone at MDH asked us if they could apply for the money, and we said no, because they weren't a county government, a tribal nation, or a nonprofit. So I think, yeah, I don't know enough about what the status of local school districts is. If I would imagine I don't know what their legal status is, but someone could go apply on their behalf and partner with them. I think there's lots of ways around that.
So I'm Connie Dagaford. This is my first meeting. I am with Early Head Start. I had posted a question just wondering if there were income guidelines with this funding. At Head Start, we have to follow federal poverty income guidelines to determine eligibility for our program. And what we're seeing is that we can serve 10% of our families can be 130% over federal poverty guidelines, which is still really low. We're seeing a gap of families that we can't serve that are slightly over income. So I wasn't sure what kind of funding requirements you have around that.
So in the legislation, there are no requirements. I think, like I said, I think really the legislation is written pretty broad. Basically, it has to be a home visit service. It has to be, the applicants have to be one of those three entities, the counties, and I think for the evidence informed, we said it has to focus on two of the key benchmarks of maternal child health. There's 8 of them that we've outlined. They're pretty broad. And it has to have an evaluation either in place or a trajectory of evaluation plan. So we would know sort of where they are in their evaluation. Laura, I don't know if you can think of anything else, but that's it. Now that doesn't mean, so I just want to go that the department itself can't say, hey, we're going to focus on families under 300% of poverty, or 100. We would never go down to 100%. That's, I think, too restrictive. But I think when we say 0 to 5, and I think I've only done the 0 to 4 numbers, but you can remind me, but isn't that like, I want to say it's like 480. How many kids is that? I'm totally forgetting the math. Oh, you're muted.
We can look that up. I do not have that number off the top of my head.
Yeah,
right
I used to know it off the top of my head, and now I can't. So, but there's 65,000 births a year. So even if we just said all those kids were here and born and stayed, so every year, right, it doubles. By the time we get to 4, we're somewhere around 240,000 kids, right? If you say 0 to 4. So, and then of course, you know, that'd be like my kid, and maybe I don't need home visiting, and so then we would go down and be like, well, what would be? I think it's around 80,000. I want to say it was 80,000. That number is sticking in my head. So, 3 million, much less our 36 million, is not enough to serve 80,000 kids. So it is always us putting priorities of like, what is are we going to do an income limit? Are we going to do an age limit? Are we going to do a service or a population limit? Because right now, if we opened up and said anyone who has a maternal child health home visiting program who's serving ages 0 to 5, come and apply, we'd have a lot of disappointed people. So we would like to tailor that in. But no, there aren't any.
Dawn, this might be this is Molly Kenny. I'm with the crisis nursing and one of the co-chairs of the coalition. Some of the things that we've talked about in the past are focusing on fathers. And I'm noticing just by maybe this money isn't directed towards that because the title is maternal child health. And so I'm just wondering how we can kind of even think about that as far as if we're wanting to put a focus on fathers, or at least make sure they feel like they're included in the fold. You know, how do we navigate through that?
You know what, Molly, I think you're catching me not using language very well. So good for calling that out. When we look at, I don't think maternal child health is in the title anywhere. I think when it looks at the key benchmarks, some of those might be like maternal health, and depression is one of the benchmarks, is one of the areas that they want to focus on, but the rest of them are much more family oriented. So I apologize, and good catch. No, I know you weren't trying to, but no, it's right. But this shows, actually, it's a good thing of like how we word something. If we don't word it, you could easily be like, oh, well, we can't apply for this, or we're not eligible. And we might be like, oh my God, we totally meant to include those people or these services or those agencies. So this is why the specifics of the language matter. So one, I would say there isn't, that to my knowledge, anything that would require us to not focus on fathers. In fact, I think that is a gap area we have thought about a lot. So now we just opened up more applicants.
Thank you for clarifying. And I totally was not calling you out. No, just checking in on my knowledge base.
Yeah.
So, okay.
No. I didn't take it that way. And even if you were, that would have been okay.
No. Thank you.
And if you guys wonder why I'm looking, I'm waiting for the city person. So everyone's, I'm just checking out the window.
Any other input or suggestions? I know we talked about some special populations, but also are there strategies that you want us to be, thinking about or to be advocating on behalf of that might lead you to need to apply for the evidence-informed or promising practice resources, because that maybe it's the process in which you want to deliver the services that doesn't fit within a model versus, a curriculum that's already there. I'm wondering if there's anyone who wants to speak to that. Because I can. One of the things that we've been talking about, again, this is specific more to the prison and jail population, is that many times people show up and if they are moved to a community alternative setting, it might not be in their home community. And so thinking about a proposal, an RFP that would be flexible enough where we could have an entity that would be the lead, but then they would be working and making referrals potentially to people in different communities across the state, and whether, it would cause us, it would just, we would have to be really creative in putting together a proposal on how best to serve the families, because right now the way we work, it tends to be place based, or community based, and it's harder to do that work when people are highly mobile, and or needing to be mobile, based on their situation. So that's just one of the things, and that would probably be true also for the for the non-custodial parent, and also true for those who are living in shelters, is that we might need to find strategies that allow us to be flexible and have a workforce that maybe is in different parts of the state even.
No, I think that's a really good point. So part of the challenge of writing the RFP is trying to envision, right? Because a little bit, I was trying to think when you said that, and off the top of my head, I'm just like, oh yeah, it sounds great. We would love to see that. In fact, we would love to be like, how could we, even in our current funding, how could we, is more money or support needed to create that early childhood system and referrals, right? And then large network, because we know the better well, both ways, these families are highly mobile, whether they're struggling and they're mobile for those reasons, or because their lives are improving and they're mobile for those reasons. It can go both ways. So we're always interested in how do we strengthen that interconnectedness and make it so that the family, it doesn't matter where a child lives to receive a public education in the state of Minnesota. It shouldn't matter where a child lives to receive home visiting. I think is kind of our same philosophy, but what's needed to make that happen? When you were saying that, I had a couple thoughts. I was just like, oh, and I think we had this maybe in the last round. I feel like this question came through I think there was a place in North Dakota, or it could have been Wisconsin, where they wanted to serve families over the border. And it was like a Wisconsin agency, and they were like, can we serve your families? And we were sort of like, oh, we weren't expecting that. And we kind of had to make a decision of like, no, we think right now we're going to stay with Minnesota entity providers, and not kind of open up that level of flexibility. I think we'd probably still be there, although I could hear arguments that would say, no, we should, if someone else can serve these families, why do we care where they are? But I think, just trying to understand. The other part is it seems to me these early childhood systems may not already exist. So how do we put money out that is, I'll call it planning or preparation or whatever you want to call it. And I think one of the things we saw last time was we've put out planning money, and then we put out operations money. And I will fully admit the timeline we had between those was not good. It was too fast. But we don't have a lot of people who go to planning, I think, because you see the needs of the families. You're like, they need services, today. So why would I wait? And yet we do see that the agencies that take that time to plan and build those networks and get the referrals and really kind of think through the logistics, that's a better place. So I wonder if that would be good input for us at some point, whether it's there or other times of like, how could we put the money out? Do we need to build a planning phase into it? Is that why people don't apply for planning? Because they're worried they won't get the next round. I think, and I guess that's a need we are seeing, is that, wow, some more preparation and planning and, support to do this heavy lift. And then trying to balancing it with like, you have a family there today that could get this service. So I'm going to add that out.
And Dawn, you actually, you highlighted exactly what I was going to bring up, which is building a system and how do we incentivize a system with multiple models to address gaps so that, everyone is able to, get that home visit that's so desperately needed. And so, for some counties that are smaller and, might only have capacity for, maybe one model at a time, how do we look at different ways in building out that system? So there is that continuum there.
the problem is I always have ideas. So but I want to hear from all of you. But I guess I just want to have you guys know that we're open to this brainstorming, and this is the time to give us this feedback, because this RFP won't come out right now. I have a target date of around April 15th. Once it's out, we can't really interact, right? It's kind of too late. You're like, gosh, I wish Don had put this in there. It's kind of too late at that point. We'd have to pull it all back. We don't want to do that. But we've thought about, like, do we put money out regionally? Do we try and layer this money? Do we say there's a sort of vanilla base home visiting, and then there's this layered on funding that we do for early childhood systems integration, for innovation practices, for regional coordination? We're open to all of that. It's just us trying to not make this 100-page RFP where you have to read through everything to know if you're hitting all the parts. And also, how do we review all of that, and how do we prioritize?
Dawn, is the RFP you said is coming out in April with the intent of what's the turnaround on that then for MDH?
Yes, and I should clarify. I'm thinking of a very large RFP that'll be about $100 million, because it'll be for 4 years.
Oh,
so that'll fund everything from January 1st, 2023 for 4 years.
Okay.
So because it's so large, that sits in the back of my head all the time.
Yeah.
We also have a small for us now is around 6 to 10 million. We also have about 6 to 10 million that we need to put out in an RFP sooner than that, which will go for other kind of to make sure we're utilizing money that's available now. So we will have that, and I don't have any timelines on that. I have one grant manager right now. So we're thinking through all of this, and we're trying to be like, how do we get an RFP out quickly? I look a lot at what other states do. So last night I was actually looking through what Oregon is doing because they got money. I was looking at Washington was doing because they got money. They released their RFP, made me feel bad. I was like, Washington released their RFP in August. They gave people 30 days to write it. They had defined practices, from what I can tell. So they said they were opening up to the kind of typical HFA NFP. They also had Parent Child Plus. They had a doula program, but I think they were defined. They weren't like create your own. It was, and then no agency could apply for more than 250,000, and their application was 25 pages. And again, it was 32 days that people had to write it. That's usually feedback we get, whether it's people we've been funding for 10 years or new communities. They're like, 30 days is not enough, much less to try and make connections, even to get their board approval. So, but they got it all out, and they're funding people starting October 1st. So I don't know what the right one is, but so April is where the large one is going out. And again, that would be for extensive. I think we have, I almost think we'll be in a little bit of a pilot because it's such new, and I will call it kind of a new focus and program. So we're on like our 5th iteration for the evidence-based. We've at least learned we're a little better at it. I think it'll take us a while to get this one right. Many reiterations of it.
Can you speak to the $6 to $10 million RFP? Can you talk a little bit about how your initial thinking about it, and then maybe folks here can offer up needs that are beyond the grant? So are you thinking about it as like capacity beyond your current grants, or things that help you do the work differently within the community, or is it for specific home visiting programming? Can you differentiate that?
Yeah. So this is only Dawn's thinking on this. So yeah, honestly, I struggle with wanting to just get this money out quickly, because my staffing situation isn't going to improve for a long time. So I'm just like, okay, how can we get this money out quickly? And to be honest, there are 2 ways to do this. Joan is going to hear this on the fly. But one way would be to sort of split part of that money. Let's just say even if we did half and half, 6 million to go to our current grantees and say, what do you need? Can you expand? Do you need innovations? What do you need to do your work better? We know that outreach is huge right now, right? Families are scared to have in-person home visiting. Home visitors are scared to have in-person home visiting. What do we need to do? And this is kind of a time limited money. So money is good until, oh, shoot, the inspector's here. Can you guys keep talking for a minute? I'm gonna go let him in and come back. And then I'll just say the other money would be, do we just sort of put out a very bare bones evidence informed with some key kind of boundaries, and then we see what falls in place. I'm gonna go let him look at my water heater. I'm so sorry.
I'll toss the softball over to Joan. Joan, if I could just get you and Don's absence to maybe speak a little bit to going back to the one-time funding and the timeline for getting funding out. I know we had an opportunity to talk with you and Don, with the executive team did, but can you say a little bit about, again, like the timeline and the staffing issues and how that might play out with the one-time funding? Can you, just so that everybody's aware of it?
Well, help me remember.
So there
lots
is,
happened.
yeah,
And,
thank you. No, that's okay. There was $4.5 million.
Yeah.
For 3 years, and it's the first 3 years of a 4-year like budget timeline.
Right.
So, so just wondering, are you anticipating that 4.5 would be part of the $6 to $8 million grant, or will be folded into that $100 million grant? I'm just thinking about making sure we can prove our outcomes to the legislature.
My guess, that's a question for Don, but my guess is that it's folded into the 6 to 10.
Okay.
Because it is money that we want to get out sooner rather than later. What Dawn is speaking to in terms of, and she has much reduced capacity in terms of her staffing, as we do across our division. So 75% of our staff were reassigned to COVID. We are having people trickle back, but she also has a number of vacancies. And because of the new money, she also has potential for hiring some additional staff to staff up. The state, during COVID, initiated a hiring freeze, and so we could not hire at all over the last year and a half. That was lifted for all state agencies except for MDH, beginning in, I think it was early August. We are slowly, and I am fighting really hard to be able to hire some of the staff, and we've been able to do that. She's now hired, I think, 2 or 3 staff in family home visiting. She did get one of her grant managers. The second one is on maternity leave, and I think comes back now sometime early fall. So, and we have one more that's in the hopper to be hired. But because we are we're in COVID land here, HR is impacted as well. And so things just are not moving quickly for us at all. But we're working hard to try and get, the staff that we need to be able to. And now, fortunately, we also have an assistant commissioner who is advocating really strongly for us as well. So I think maybe things will improve, but the process isn't a quick one.
Thank you. I just want to make sure everybody is aware of that, and the coalition and many of all of our partners here stand ready to be helpful, right? So we don't want to, if we beat on some windows or on a computer screen, it's not about you all. It's about how do we make sure we're getting resources to families, and
absolutely,
we don't want anyone to feel bad about it. We just want the families to get served. So
yeah, no, we do too. Most definitely, we're with you 100%, 200%.
Exactly.
And if we could make it different, we would, absolutely.
Great.
It's not been a fun year and a half, as it hasn't been for any of the families, and it's we all have suffered.
Right.
Most definitely.
Yes.
So the water heater passed.
Yay!
In case you're all sitting on edge. I'm so sorry. But so I'll catch up with Joan and Laura about what conversation I missed. I know I
Joan
was.
or Don, maybe you could just, one of the questions that Joan wanted to make sure we clarified is, I was asking do you anticipate the one-time funding, the 4.5 million will go out in the $6 to $10 million RFP, or do you think you'll fold it into the $100 million RFP? And mainly because of timeline, and we want to be able to help support the communication around this. So.
Yeah, to be honest, it might be a little bit of both.
Okay.
So the 1.5 million for this year and next year, we would likely put out in this sooner RFP, or at least for sure the 1.5 million for this year, right? And then a good part of, not all of the other one, the 1.5 in the last year, we might roll into that larger RFP. One thing I probably didn't say well is we will be splitting up RFPs there'll be an RFP for the evidence-based that will be very clear, and that'll be largely that $100 million one. We will also have probably a second RFP out at the same time that will go for evidence-informed promising practices. And that's why, in part, I almost want to do this pilot RFP to one, just get the money out. Two, we know there's a need. I could plan forever, and I don't know that it'll actually make a big, I don't know that any decisions I'm going to make of details is going to make a big enough impact that why would we hold the money? So let's get it out. And I think what we'll learn will inform that next round, if that makes sense.
We have two questions in the chat, so thank you. It's really helpful to hear all of this. Do you have a timeline for the $6 to $10 million RFP? And then also, will the NFP grant be folded into the 100, the big RFP, or will that be a separate grant process?
So the timeline for the 6 to 10 million, no, other than getting it out soon. I don't even know. They're going to be like, what are they doing at MDH? It's literally trying to figure out what could we write and put out that could be clear enough that people could apply and wouldn't require a huge a review process, because we don't have the staff capacity to do that, to hold a community review process, to do a lot of time ourselves. So to be honest, the easier we can make the whole RFP process on both ends, writing it, right? You guys are in the middle of a pandemic. You don't have time to write a big application either. So it's really just trying to make that a doable one. And I don't know our timeline. I mean, basically, I think it would be me writing it. So maybe we would try and release it by December. Will the NFP be on the same time as the larger? Yes, we are going to roll all evidence-based restricted funding into the same money. Now, right now we do have our NFPers who their grant ends this end of December. There's only 5 of them. We are going to ask MNB for another exception to extend them, because MDH we're only allowed to give a grant for up to 5 years. Once we reach that end, we're supposed to give out new grants. We are asking for exceptions to decrease paperwork on both ends. We'll be in their 6th year now. So I don't know if MNB will approve that or not, but we're going to ask. But largely all evidence-based will roll together. So MICV funding, which is evidence-based, the 75% of the I'll say 16.5 million because that's in general what it is, right? The 1.5 is kind of an addition to it, and then the 2 million for NFP are evidence-based pot that we think of going forward. That's how we came up with around 100 million will be the big RFP.
Great. Okay. Well, this was incredibly helpful. I really appreciate you both being with us and giving us your ideas and early input and getting information and getting ideas and input from many of us in the community. I think that's really helpful. We really have appreciated the partnership. So we'll continue to watch. If people do not already know, the Department of Health and Family Home Visiting section has it's currently weekly. It might be monthly soon. No, I'm just kidding. Tuesday topics, depending on staff ability, but they do have regular communication. And I'm happy to send you the link, or Dawn can put that in the chat if it's easy enough to do, or we can send it out afterwards as well. But I want to make sure you're getting regular communication from them, and we try to stay in close contact with the Family Home Visiting section, as well as many of the others at the Department of Health. We welcome you to stay put and continue joining us for the next section of the meeting. We're going to talk about the Healthy Start Act, and I'm going to turn it over to Molly.
Yeah, thank you, Laura. We're really excited to welcome Sophia.
Sophia, yep.
Sophia, I hope I'm saying that right, as well as Rebecca Schleifer, who we've had present to us in the past and had some really good discussion with. And that they're here to talk to us about the Healthy Start Act that the coalition helped to support, and had really good testimony and letters from others. So Sophia is with the Government and External Relations Department with the Department of Corrections. And Rebecca Schleifer is with here from Rebecca is with
University of Minnesota.
Sorry, Rebecca. I'm like I couldn't get the words out. Yes, I apologize for that. So Department of Pediatrics. So I appreciate you being here. Kelly Heffort and Lori Timlin are also with us today because they are leading the implementation of the Healthy Start Act. So we would love to hear from you guys. We're excited you're here. We appreciate you taking the time, and we'll have some questions. We'll save some time for questions. So thanks for joining us.
Thank you so very much, Molly and Laura, for inviting us again. We are really grateful to come join your group and have this discussion. See a lot of new names too. I know there was some folks that I think we have spoken with before, but many new names here as well. Before I get started, I did want to highlight, thank you for also welcoming Kelly Heifert, the Director of Reentry Services at the Department of Corrections, and Lori Timlin, our only parenting coordinator at the DOC. I'm really excited to announce, and we'll talk about this a little bit later, that more recently in the last couple of weeks, both of them have graciously stepped up to co-lead the implementation of this program and policy. So, as we move into that phase of this work, you'll be hearing a lot more from them. And this is, also a connection point for us to introduce them and kind of hand this work over to them and see the wonderful things that they do with this authority. So I also want to really thank you. I don't think we've had a chance to touch base with each other since the session. So I really want to thank all of you for the support that you have provided, this session for the Healthy Start Act. Your letters, your communications with legislators, and, just your general support was so helpful. If you haven't heard from me before, I'll tell you this is a new area for us to step into. The Department of Corrections doesn't bring legislation in the early childhood space. And this is years in the making, and the three people I have here with me are, I would say, some of the few people responsible for this at this agency level, pushing us to do better, having us look at these intersections. I'm really grateful to Dr. Schleifer always, and then, Kelly and Lori for the work that they have done to bring us as far as we've come. So with that, I'm going to start with a presentation. Today, Dr. Schleifer and I will tag team a little on the PowerPoint itself, but then Kelly and Lori will join us in the discussion phase and help us answer any questions. And just because I know that there are a lot of new faces, we also wanted to kind of go back into the background a little bit as well, just also as a refresher, and then dig a little bit into what the actual law does, and answer some questions around implementation and give you some timelines. So I'm going to start sharing my screen. And hopefully you can see it here soon. Just let me know when you do. If somebody could maybe unmute and let me know if you can see the screen, that would be fantastic.
We can see it.
Wonderful. Thank you so much. So we'll get started. I'm not actually going to go into full PowerPoint mode, but I have minimized the left bar just because every time I do that, my computer gets stuck. So yay, technology. I'll just move it forward as it is. So as I mentioned, we're going to talk a little bit about the Healthy Start Act. But before we do, because this is a new space for us, I want to just take a couple of minutes in the beginning to talk about who we are as the Department of Corrections. After that, we'll go into the overview of the Healthy Start Act itself and look at some data related to incarcerated pregnant women. And Dr. Schleifer can also speak to, women who are incarcerated and immediately postpartum in that first 1 year period as well. We'll give you a little bit of an implementation update and timeline and run through some frequently asked questions and then just open it up for questions and have a discussion. So just a little bit of a background on DOC by the numbers. I like to just show the slide when we're entering a new space, just to show you that, we are a gigantic agency. We are about 4,200 staff all across the state, 10 prisons and 17 statewide field supervision offices, as well as the central office where I am sitting right now. And so our staff are all across the state, and we are the third largest state agency. We have about 20,000 folks who we supervise as a Department of Corrections in the community, but we also oversee the entire supervision system that has almost 120,000 people on it at any given time. So we work very closely with our county partners on that. They lead the supervision and we fund that subsidy and oversee it. We traditionally, before COVID, have had a population in our prisons of about 9,200 folks. Since COVID, so we're looking at just a snapshot in time on January 1st of this year, we were looking at 7,325 folks in prison. So population has decreased quite a bit. And Lori will tell you this, during COVID, we had very few pregnant women who were coming into our prisons. We're still in COVID times, it's not over, but over the last couple of months, we've seen an uptick in the number of pregnant women who've come through our doors. So the other thing I want to highlight is, that 95%, over 95% of the people who are incarcerated do come back to the communities they are coming to us from. So that's about 600 people a month are released from DOC pre-COVID. And I share that to say this is the work that we do every day: re-entry, release planning, thinking about that community connection. So it is really critical to us, and that's kind of where we are headed as an organization, is focusing on that healthy connection back to the communities that folks are coming to us from. And then just real quick, just kind of org chart, just to show that we are a lot more than just prisons, right? We are about treatment and programming and education. We have our organizational and regulatory side of things, but a lot of the work that we do that happens on the ground, led by our amazing staff, such as Kelly and Lori, happens in all these other areas that are often kind of unseen when we're talking about the Department of Corrections. So we are more than just security, and we are hoping to kind of rise to that occasion of showing that we are more than just security. So all that kind of brings me to, the Healthy Start Act. And I wanted to just play some of these quotes that Lori had gathered from women that she has worked with in Shakopee over the years. And I know she had shared this with me as part of a different legislative proposal initially when I first started here, and just really touched, my soul reading these words from the incarcerated moms. But while I have it on the screen, I want to talk a little bit about what the status quo is. So what happens today before the Healthy Start Act is implemented? So what happens is, a person will come to us, and if they are pregnant, oftentimes, and Dr. Schleifer will run us through this data in a little bit, oftentimes they're coming to us for technical violations of supervision. That's the most common, governing issue that they're coming to us for. And oftentimes they're coming to us for short durations of time, but they'll come in and they will give birth while they're incarcerated. They will go to the hospital, they'll give birth. And just like any of us who give birth in a hospital setting, they have about between 36 to 72 hours, depending on their situation. And at at that time, they are separated from their baby, and whatever the baby's plan is, whatever the plan for the child is, such as going to a family member, going to a volunteer family, etc., that takes place at that hospital setting, and then the mom is coming back. COVID has exacerbated the situation, but even before that, visiting is not easy. We have one women's prison in the entire state, and that is in Shakopee. So it means you could be from any part in the state, and the child could be in any other part of the state, and the mom would be in Shakopee. And then there's just additional barriers to being able to visit the mom, such as lack of transportation, lack of someone having the capacity to come and bring the child in. So a lot of barriers there to promote a healthy bond between the mom and the child. So, our teams that work with women, Dr. Schlafer, our partners at the Prison Doula Project, have been raising this issue for many, many years now. And as a part of these conversations, we looked at a variety of different solutions. We looked at what other states do and found that most states where there is some sort of a program, it is really focused on a prison nursery type of setting, which is where the babies are then, in the prison setting with the mom for a duration of time. I'm originally from Pakistan. I grew up there, and I know in Pakistan and India, that's a very common model. I mean, up until, you're 6-7 years of age, you might be staying in that prison setting with the mom if the mom has a lengthy sentence. So that's not uncommon in other countries. In the US, it doesn't happen everywhere, but there are several states that have a prison nursery model. And this is a very, very expensive model, right? Everything, any type of programming, any type of addition that you do in a prison setting is going to be expensive by way of having to, account for security staffing and all sorts of logistics within that setting. And then also, thinking about the outcomes for the child, we thought a lot about, is it the best place for the child to grow up, in a prison setting? In Minnesota, the Commissioner of Corrections has conditional release authority in other places. We have a work release program that Kelly and her team oversee. We have a conditional medical release authority in very specific situations where we can, usually end of life type of situations, where we could potentially release someone. So we modeled the Healthy Start Act after those. We thought, this is a special population. These are special circumstances. And this is not a unique program in the sense that, again, we have a work release program. We have other types of releases that we do. This is a special population that we could potentially apply that to. So that's where the proposal came in from, and then supported by all of you. And I don't want to discount all the work that I think many of you in the field have done that, maybe didn't ever reach the Department of Corrections to support the very families and the very women that we are talking about. So I'm going to actually give it over to Dr. Schlafer to talk about some of the data that we have. And I know she has a lot more, but we'll keep it limited to the data that was related to the Healthy Start Act today.
Yeah, thanks, Safia. So I am wearing multiple hats today. So I am a researcher in the Department of Pediatrics at the University of Minnesota, but I've also served as the Director of Research for the Minnesota Prison Doula Project for the last 11 years now. And since our very first birth now more than a decade ago, we have been following the birth outcomes, maternal health characteristics, and needs of all of the pregnant people who have delivered in custody with the support of a doula through the Minnesota Prison Doula Project. I should also say that in addition to doing research and evaluation with the Prison Doula Project, we have also done a number of research projects in partnership with the Department of Corrections to better understand parents broadly in the Department of Corrections. So what do we know about parents in prison? And have done some research looking at children's outcomes when they're born to moms in prison, and that research is forthcoming, and I can share much more than what we'll share here. I do want to acknowledge that, not unlike other states, Minnesota does not systematically collect information about pregnant people. We have very poor data in our state about pregnant people. We have a paper medical record at the Department of Corrections, and what is there is very hard to use in terms of research. So Safia has pulled some information here, and we have others the other data from the sample of clients who have delivered with birth support, but just some high level overview here. So what we were able to pull from the system between 2013 and 2020 is that there were 278 pregnant women who were serving a sentence in a Minnesota prison. Again, a proportion of those who will get out. And this doesn't include jail. So a quick primer, which Safia didn't talk about, but I think is important, is that these are just for individuals who are sentenced to felony level sentences. So we know that there are pregnant people in jails all across the state. We know very little about them too, but I think when we think about intersections with family home visiting, that's something that needs to be on our radar. So just some quick demographics here. You can see that among the pregnant women at Shakopee, 34% of them were Native, 12% of them identified as Black, and just over half identified as white. I want to acknowledge that that is even more racially disproportionate than the rest of the women's prison population. So we know that women who are pregnant in prison are more racially and ethnically diverse. They're younger in age, and they have fewer years of education relative to other women in prison. So there are a number of what we would consider risk factors for poor maternal and child health outcomes, but also that is tied into key characteristics that would put them at risk for recidivism too. And the racial disparities here are really profound. As you saw here, 77% of them were in for technical violations, meaning they were out but got brought back in. Other key highlights here, more than 3/4 of them were sentenced to prison while pregnant for less than 9 months. And this is something that, I remember a conversation with Nan Larson at the DOC back in 2014, that this to me was one of the key pieces of information, along with the median length of stay in prison as 4.5 months. When we think about a person coming in pregnant, being in an environment that was not designed for pregnant women, being in a space that is not healthy for pregnant people to be in, and then being separated from their babies for what is really amounts to a relatively short period of time. We've separated moms and babies in a critical developmental window, and have missed an opportunity for moms and babies to bond and be together and breastfeed. And we know those moms are getting out and they're returning to caregiving roles in many situations. And so to me, this always felt like two key pieces of data just about how long they're going to be in and how long until they're reunified with their babies when they get out. So you can see there that 41% of mothers who gave birth while incarcerated reached their release date within 90 days of giving birth. And for folks who work with moms and babies and families like this group does, that those first three months are so critical for co-regulation of babies' eating and feeding and sleeping cycles, and our moms are missing those opportunities. And then you can see the other stats there in terms of release date to birth, which I think are really critical. And then we've got some other data from other sources looking at just what we know about the caregivers who took custody of the babies at the hospital. So Safia mentioned, right, that moms are transferred from the prison to the local hospital for delivery. After about 36 to 72 hours, return to the prison, and the babies are released to an elected caregiver. And in most cases, a maternal, someone who is related to mom, a kin provider, very often maternal grandmothers. And I can share some information, some more information about that if folks have questions on that. But we know that those caregivers, right, because Shakopee is the only women's prison in the state, we have women who are incarcerated from every county across the state. So babies are going back to live with caregivers all across the state too. And on average, those caregivers live about 120 minutes or about 2 hours away from the prison. And so imagine, right, being a caregiver, wanting to maintain a relationship with biological mom, but not being able to make that 2-hour commute, really 4 hours, thinking about driving back and forth with a brand new baby to maintain any kind of relationship. And about 56% of caregivers who participated in this one study that we did reported never taking the baby to the visits for the prison. And again, just huge barriers in thinking about getting those babies there for any kind of regular contact. And it's not like, and Lori can talk about this more too, it's not like once they get there, those are really healthy environments for babies and moms to be in. There's not much for them to do. It's not a nurturing and welcoming environment. And they're limited in really what moms can do with their babies in that space. Safi, I don't recall if the next slide's mine too. Do you want to advance? Or I'll pass it back to you. Is there
Yeah.
more?
No,
Okay.
that was it for data, but thank you so very much, Dr. Schlafer. I mean, as you've heard, I think Dr. Schlafer has just a wealth of data and information if folks are interested that she can share, and we've been really grateful for this partnership. You don't need to read all of this. I will certainly be sending this PowerPoint out, and I have this divided up in smaller sections in subsequent slides, but just wanted to show that this new law went and became a part of our existing work release statute. So we have work release in statute already, and now we have this very specific conditional release for pregnant and immediately postpartum women part of it as well. So the purpose and authority of the Healthy Start Act, under the Healthy Start Act that the commissioner has received, is to be able to conditionally release people who are pregnant or immediately postpartum to community-based programming, and the purpose really is for participation in prenatal or postnatal care programming and promotion of mother-child bonding. Other programming requirements can be established by the commissioner, and we anticipate will be established by the commissioner. And that can include an array of things, such as evidence-based parenting skills programming, mental health and chemical dependency treatment services, etc. Again, not uncommon. This is how some of our other release programs are also set up. So then this is the eligibility that we set in the statute. So it is for one, pregnancy and beyond, for the duration of pregnancy and up to 1 year postpartum, if you are coming into prison and getting committed to the Commissioner of Corrections while you're pregnant. And if you are postpartum upon commitment, so if you're within 8 months of having given birth, it is for up to 1 year postpartum. So if somebody is coming in at that 8-month mark, they could at the most have 4 months in the community. If somebody is coming in at the 4-month mark, they would have up to 8 months in the community. But both are consistent, so the maximum amount of time that you can have under this program is 1 year postpartum. And I have it might raise some questions, and I do have those in a frequently asked questions slide later, so we can run through that as well. And then just the deliverables, like what are we required to do under this act? We are required to develop a policy and a criteria to implement this law. And that is the work that Kelly and Lori are working on. So we kept the language very broad, very deliberately, and also it is consistent with how broad other release authority that the commissioner has is. Commissioner of Corrections often has very broad release authority, and then in policy is able to set those other eligibility criteria and how that authority will be carried out. So we kind of model it after our existing authority in other places. And then we also built in some reporting requirements for the department to report to the legislature on the number of folks who are released every year and the duration of their release under this act for the prior calendar year. So that will start in April of next year. So that brings me to the implementation side of things. I'm not going to go through all of their bios, but you will have this PowerPoint so you can see how amazing the two folks who will be leading this are. But I think they also bring really rich background and expertise to the table in developing this program and policy. And I'm saying program and policy because the statute just requires us to develop a policy. And the easiest thing for us to do would have been to put a 2-page policy together and roll it out. That is not what we are intending to do. We are intending to be very thoughtful in how this is developed. We want to make sure that the development of this program and policy engages impacted individuals and our partners. It also is our intention to make sure that we are setting people up for success when they are participating in this program. So it's not simply about releasing, but making sure that we are ensuring that there are resources available in the community that they're going back into, and that we are working with our partners where resources are not available to maybe create those resources. And then we really are also striving to build in an evaluation process so that in a couple of years we can come back and say, is this working or not? And if not, what are those things that we need to do to get there? Our timeline is, so as I mentioned, just one thing to note is that we had divided up the policy and the funding side of this legislation. The policy passed in May, but as you are aware, the legislature did not actually end up passing our budget until June 29th for public safety and corrections. So we weren't certain if we were going to actually get the funding for this program. We had requested $200,000 a year to start off with. We received half of that funding. If we had received no funding, we could possibly not develop a program. We could still use the authority in some situations, and here and there, but having $100,000 a year is a good starting point for us. So we are hoping to develop an actual program under which folks can receive these community alternatives. So I'm going to go into some questions and then we can open it up for discussion. So, one question, and Dr. Schleifer talked about this. The first question is, will this apply to women in jails as well? And it will not. So this is really focused on the Commissioner of Corrections Authority. The women who are in jails are really there either pretrial or they're there post-conviction because they have received a sentence of less than a year. So if they're not pretrial and they're serving a sentence, it's often because they're serving a sentence of less than a year and a day. And if that is the case, that is a judge who is responsible for allowing them to be released. I know in some counties, they do go back to the judges and the judges do grant furloughs to women who are pregnant for a duration of time, but that varies. And I know Dr. Schleifer works a lot with the jails and could speak to that as well. So this act is really focused on the women in Shakopee, the women coming to the state. Will pregnant women still be sent to prison? Yes. So this is not something that is going to be automatically decided from the bench. This is not something that a judge will be granting. This is something the commissioner has the authority to be able to implement. So when somebody is sentenced, their sentencing order will say, the judge will say, you are going to Shakopee or you're going to St. Cloud. Those are our two intake facilities. So they will still come in, there will still be an intake and assessment process that will hopefully be fast-tracked for this group of folks. And then that's when we will identify what needs exist and whether or not those needs can be met in the community. And hopefully our intention is to be as inclusive as possible as we develop this program and policy. But this is not an alternative to a sentence. This is post-sentencing release, conditional release. So do individuals still have to return to prison to serve their sentence? So this is a question that comes up often, like, is the sentence running at the time that they are in the community alternative? I think that's actually a better question. I will change the wording, but yes, they are serving their sentence in a community alternative for the purpose of this program. As Dr. Schleifer shared the data, majority of these women, about 76% who give birth with us, get released within that year mark. That's where the number came from for us. Out of the 40 women a year who come through our doors pregnant, about half leave while they are pregnant because their sentences are so short. Just about 20 women a year on average who are actually giving birth while they're incarcerated. And amongst those, about 76% are reaching that release date and they will not have to come back to serve their sentence. If somebody has another month or two left and they are in this program, they would be returning. I mentioned that the most times that someone can spend in a community setting with their child under this law is 1 year. So that's another question we get, is how long? And then if someone has a 5-year sentence, we hear variations of that, or any number of like a lengthy sentence. Will they have to return to prison and be separated from their baby at the year end mark? And that is something that is going to be at the crux of us developing this policy and this program, because all that from every child development expert, what we've heard is that separation would be detrimental. It is a really hard thing to put in policy, but the reality is this legislation is not going to help every single pregnant person who walks through our doors. It's really meant for those who have, which as our data shows, is about over 75% of those cases where people have shorter sentences, up to a year-long sentences, maybe a little over a year. But we wouldn't want a situation. The whole purpose of this was to not have that impact of the separation on the child and the mom and the child bond. So we wouldn't want a situation where someone has bonded with their mom for for a year period, and then is being separated because the mom has to come back and serve a sentence. So we haven't figured out all of our eligibility criteria, but it is very likely that those with lengthier sentences are not going to be eligible under this program. Where will the women be housed? Our language is really broad, so this could look like, halfway houses, treatment facilities. For those who would fit the bill, maybe adult foster care homes. It could be anywhere where they could get treatment and programming. And then what kind of treatment and programming will be available to women? And that is also the work over the next few months, is to do the inventory of the different programs that exist that could support moms with young babies. We have a few in the state. We could use some of the money that we got to develop some more, work with our partners to develop some more in the community. But it could be a range of different types of programming and treatment depending on the needs of the women. Not everybody will have treatment needs. Not everybody will have, chemical dependency needs. So depending on what those needs are, we would do an inventory of the programs and do our best to make those available to the women. And then, can someone participating in this program be revoked to prison? And the answer is, unfortunately, yes. If it is a conditional release program, so if there is an impact on public safety, similar to our other release programs, there is the ability to revoke someone back to prison under this program as well. So I'm gonna just show our contact information. Dr. Schleifer took the liberty of adding your information into. People can find it on Google too, but here we all are. And then I will stop sharing my slide. You will receive this PowerPoint, and just see if folks have any questions or any discussion, or we are all gonna tag team on this part, so.
That was great. I love the FAQ because there were a lot of questions in there that I know that people had questions about. So I'm wondering if I can just tee it off. Sorry, Molly, I just jumped in on your section of the agenda, but I would love to throw out the idea of how these new home visiting funds might support the work. And I think our colleagues are still with us. So just wondering if any of you, Kelly and Lori, I know you're going to be implementing it, but wondering if you have any initial thoughts around maybe what you heard, because you were here earlier to hear about the home visiting as well.
Yep.
Hi.
You go, Kelly.
One of the things that we were visiting with a residential community center in the Twin Cities, so that provides work release for women, and would likely be a good partner, right, in this program for Healthy Start. And one of the things that we were talking about is, right now, Department of Corrections, we pay for bed spaces for people in transitions, right, at our halfway houses, but we don't typically pay for children, right, or pay for babies. I mean, we would under this Healthy Start, but what are the supports and services that people could get on site then as part of this program or others? And if mom under Healthy Start and her baby are at one of these halfway house programs, what's the ability if she has other children, right, to come on board or together for all of them to receive services? So it makes no sense that kids might remain in foster care if she has others and she has this baby. But what are the avenues then for some blended kinds of funding, or at least for families to get support together? And maybe there's some opportunities for in-home visiting to bring families together, whether they're residing together or not, but to support mom and baby and other children that she has. So that was one interesting thing. So I was happy to hear this as part of the conversation today, and kind of looking forward to dig into what those RFP possibilities might be for some of our partners. And I did mention it as well at the Minnesota Interagency Council for Homelessness this last week to say, it doesn't make sense, right? We all pay for these bed spaces for individuals in our programs, but where do we actually put families' needs together?
And it's beautiful that you said that, Kelly, because right now I'm aware that 4 of the women who are incarcerated here who are pregnant, this is their first pregnancy. So I'm thinking in terms of them being able to form relationships with that visiting nurse, who can do a ton of skill building and training and education. So I am really welcoming the possibility of them receiving services, which is also part of why I've also always thought there are some pluses to having a prison nursery, because sometimes we are working with women who do not have a strong support system, have not had people who have assisted them in learning how to parent. And I think that the women would really welcome having that visitor coming in, wherever they might be.
I know that Dawn and Joan and I have talked about in the past. I mean, for me, there's so many natural intersections between this and the opportunities for family home visiting. For folks who are not immersed in the corrections world, I think one of the things that's really important to know is that when people are incarcerated in a jail or a prison, they're not eligible for Medicaid. And so one of the many things that I think this law opens up is opportunities for most of our clients who would be income eligible to have Medicaid, and changes in our state now, which would allow women access to services long past than they used to. It's both, physical health services, getting to see a doctor in the community, and then all of the things that will open up for their infant in terms of Medicaid, but also thinking about programs and services like WIC and family home visiting that women who were incarcerated before were ineligible for because of the Medicaid exclusion policy, that now we can open up all these things that we have in the community that they would otherwise be eligible for because they're no longer incarcerated. And so I think it is about figuring out the menu of services that a person needs, what's available in a community, and matching the menu of available things and using the resources that already exist that they were otherwise ineligible for during a period of incarceration.
And Rebecca, one example of that is frequently women are not familiar with the vaccination schedule for children until they become school age. And so that would be a wonderful opportunity for kids to be immunized and moms to be educated about when those are required. And then if I could just add one more, I just want to give you an example. We recently received a woman here. This is her first pregnancy. Her commitment offense was in 2014. So she's been on supervision for 7 years, no new offenses. She used, which clearly is a violation of probation. I suspect she may have been sentenced to Shakopee because she's pregnant. And had she received services, would she even be here? And she has 1 year to serve. So she's got everything that we have talked about that lends itself to really, I think, reducing the possibility of her returning and allowing her to have a relationship with her first child in the community while being educated about resources that she can access. She's very young too. She was only 19 when she initially committed the offense. So the possibility of her continuing to have children is relatively high. So
I mean, I think people are already thinking about the collateral consequences. Had the Healthy Start Act not been available for a client like Lori just described, right? That mom runs the risk of permanently losing custody of that infant because of her incarceration and the likelihood that someone is going to move in to have a child welfare case open, or she's temporarily separated from that baby, but not able to reunify in a meaningful way after not having a year with that baby, not being able to breastfeed, et cetera. I mean, so I think there's so many dominoes that fall when we're separating moms and babies when incarceration occurs that I think this law has the potential to help right some of those wrongs.
This is Donna. I took so much time, I don't want to take a lot here, but one, I would just be like, yes, I see all the connections, and so we have funding, right? So what limits we would have when, Kelly, when you were saying, we have funding for space for the mom, but not for the baby. So one of the things we can't do is we can't buy rent, or we can't, pay. So I wasn't sure how broad you were thinking there, but certainly in terms of services we can. And this is maybe where, again, we're trying to get the money out quickly, and identified needs is, it may be in our best interest to do small RFPs that are very focused. So maybe we get a little work group together and we figure out the best sort of program focus. These programs should focus on this, and maybe one is just on jails and corrections. And eligibility is this, however broad or restrictive, whatever that work group quickly decides. And then we put out an RFP on our end that says we are soliciting for home visiting services that meet these criteria. And then, you get that out. And then we may do a separate one on homelessness and a separate one on BIPOC. And I'm sure if you're one of our grantees and you're like, but I want to apply for all three, that would be the messy part, but it would get the funding out quicker and probably be a little more doable. So I'm just saying we would be very open to that. And you guys are the experts, right? For me, I'd have to be like, well, what would we want this program to look like, and who would be eligible, and what am I not thinking of that we're going to get this? So, yeah.
Great. I am recognizing the time, and really, Dr. Schlafer, you did some nice foreshadowing for Gina, who's up next to talk about the intersection. That's why we wanted to bring all of you together today, because the next policy change, I think Renelle is going to key this up, helps tie all of this together. So Renelle, I will pass it over to you to help tee up this next conversation with Gina.
Okay, good. Good morning, everyone. So I am excited to introduce our final guest for today, and that is Miss Gina Savage. And this is a part of the MA extension, postpartum. And with that, this is a policy issue that the coalition has helped support this year with legislation, with advocacy, with written testimony and letters. And so with that, I want to introduce Gina Savage, and she's the agency policy specialist, the healthcare access and eligibility person from the Department of Human Services. So once she is done with her presentation, we will have time for questions, but we just want her to be able to share the implementation of this and the information, and then how we can help educate people about these pregnancy issues. So welcome, Gina.
Thanks for having me. I appreciate the introduction. I work at the Department of Human Services in healthcare policy, specifically eligibility policy. And we have been working on we've been looking into this for several years. So it was very exciting that this finally passed this year. We're excited for rollout and implementation. And I just have a few slides that I wanted to share to kind of level set and get the discussion rolling. And I'm happy to discuss and get some feedback specifically about outreach at the end. So, and if you have questions, feel free to interrupt. I'm happy to answer them while we're going through. So just kind of general background, a pregnant woman eligible for medical assistance is entitled to receive coverage from the date of her conception until the last day of the postpartum period. The most recent special session extended the MA postpartum period from the 60 days that we're pretty familiar with to the 12 months following the end of pregnancy. So specifically, it modified 3 sections. It redefines pregnancy to include women who are pregnant for the 12-month postpartum. So like modifies the actual definition of pregnancy for MA. It requires a redetermination of MA eligibility following the end of the postpartum period. So women who are no longer than postpartum period are required to get their eligibility determined for other healthcare programs, whether that's MA, Minnesota Care, tax credits through MNsure. etc. And then finally, the last section is specific to women who are not eligible for MA due to their immigration status. And then those, we've also extended the definition of postpartum to be from 60 days to 12 months. So just some high level impacts of what we are envisioning this is going to mean for Minnesota. CDC data shows that 24% of pregnancy related deaths occur in the 45 to 365 day postpartum, as opposed to the 19% of maternal deaths that occur in the first 42 days. Clearly showing that we need postpartum care past the first 60 days. Not all postpartum issues arise in the first 2 months. The racial and ethnic disparities in pregnancy-related deaths are considerable. It's about almost 41% higher for African-American women and almost 30% higher for American Indian and Alaska Native women than all other groups. And then 60% of those deaths were ruled preventable by the CDC. And then 11% of Minnesota received no postpartum care, with women of color, low-income women, and mothers of children with special needs experiencing the most barriers to receiving those care. In Minnesota, approximately 20% of pregnant women are determined ineligible for MA following the end of the current 60-day postpartum period, about a little under 1,200 women per month. The remaining 80% are redetermined eligible into another MA basis. So this could be the MA as a parent. If the pregnancy did not result in a child, they could be eligible for MA as an adult without children. And then the other 20% are either redetermined eligible into Minnesota care, maybe tax credits, or due to immigration status are just not eligible for MA following the end of the postpartum period. And we're specifically excited because extending the postpartum period to 12 months aligns the mother's coverage with her child's coverage, because a woman who has a child while enrolled in MA, that child is guaranteed MA coverage for 1 year until their first birthday. So aligning the mother's postpartum care with her child's guaranteed coverage encourages formerly pregnant women to seek care at the same time as their child. So a little bit behind the scenes data, Minnesota covers pregnant women through 2 different funding streams. So we have our MA pregnant women. These are women who are pregnant and in the postpartum period and meet all other MA eligibility criteria. And then we are eligible, we get about 50% reimbursement from the federal government for these individuals. We also have what we call our children's health insurance, our CHIP funded pregnant women, excuse me. And these are women who are pregnant or in the postpartum period and meet all other MA criteria, except for an immigration or citizenship requirements. And these are mostly undocumented pregnant women. So CHIP funding is very specific. In Minnesota, actually I should say just in general, states are not eligible for MA reimbursement for the postpartum months. So how we do this in Minnesota is we actually prepay when a woman's pregnant and as a CHIP funded pregnant woman, we actually prepay for months 1 through 9. And then the 2 months postpartum are with our zero pay. So this is because there are some federal regulations that allow us to cover if a undocumented woman is pregnant. The child that she's carrying is considered an American citizen, and we can provide services to the woman because she's pregnant. But once the pregnancy ends, she's not eligible for those funds. So the postpartum months from the extension from this recent law will be entirely months 3 through 12 will be entirely state funded. We won't be making changes to how we're funding pregnancy months 1 through 9 or months 1 and 2 of the postpartum period. Back in March, the American Rescue Plan Act was passed, and this created an option for state Medicaid agencies to extend the postpartum period to 1 year following the end of pregnancy. This state plan amendment allows Minnesota to receive federal funding, the additional federal funding that we get for pregnant women for that are MA PWs. It's time limited to 5 years, begins in April 2022, and then ends March 31, 2027. The Minnesota law, however, is not time limited. This is a permanent change in law. So we're hoping that the federal government will remove the time limitation eventually, especially if it's a successful rollout. But in Minnesota, we would continue it past the 5 years. And then I should mention that the state plan option under the American Rescue Plan Act does not apply to CHIP pregnant women. Minnesota law states that if federal approval is not obtained to cover these pregnant non-citizens, then coverage will be entirely state funded. And we don't anticipate that we will get federal approval. So just a little bit about implementation. I know folks are really curious. The extension is effective July 1, 2022. So just, I guess, 10 months from now, next summer. So women who are pregnant and within the 60-day postpartum period as of July 1 will have their postpartum period extended to 12 months following the end of the pregnancy. That'll just be an automatic, and we'll send out a letter informing them of their change. All new applicants and enrollees who report a pregnancy after July 1, 2022 will have their eligibility determined to include a 12-month postpartum period. And then this applies to all women determined eligible for MA for 1 month or more, including during a retroactive period. So for those of you who are not familiar, when a person applies for MA currently, you can actually request retroactive coverage, which is coverage up to 3 months prior to the month of application. So if a woman has a child and the pregnancy ended 2 months ago, and her postpartum period, the last day of her postpartum period is this month, she'd still be eligible for that extension. And then the postpartum the implementation will exclude women, the rollout will exclude women whose postpartum period ends on or before June 30th, 2022. We have a hard start date of July 1. And then pregnant women who are only eligible for labor and delivery under emergency medical assistance. EMA does not provide for a postpartum period, only for the payment of the labor and delivery. So we're not creating a postpartum period for women who are only eligible for EMA. Just kind of a high level about our effective dates. Minnesota is a full coverage month. So the postpartum period will last from the first day of the month following the month the pregnancy ends, all the way until the last day of the month in which the pregnancy ends. So if a woman delivers a child on September 12th, the postpartum period will begin October 1 and will end on September 30th, 2023, which will align with her newborn's coverage because the newborn will have automatic MA through the end of the month of their first birthday. Our IT estimate is approximately 11 months for completion. So project work has already started. We've started drafting requirements. We're working with our IT systems to get this up and going. Some of the IT work includes things like updating the postpartum period in the systems from 60 days to 12 months for both our MA and our CHIP funded pregnant women. Creating a new state funded CHIP code to make sure that we're properly funding these women. And then also all kinds of testing to ensure that our eligibility and coverage systems are working correctly. I've had a few questions about how this extension might interact with the end of the public health emergency. So throughout the COVID-19 public health emergency, states are able to receive an additional 5% federal funding if they maintain enrollment. And that includes things like not closing coverage during the public health emergency if someone becomes ineligible, with some exceptions like death, moving out of state. But mostly, we're not acting on adverse changes in circumstances. So if someone reports an increase in income, someone doesn't pay a premium, if someone becomes eligible, a pregnant woman who might be normally eligible for Minnesota Care, we're just keeping her as an MA pregnant woman throughout the entire duration of her pregnancy, or throughout the entire duration of the public health emergency. We've also suspended most of our renewals and any kind of data matching to do income verifications, just so that folks who are able to access healthcare throughout the entire public health emergency. These rules do not apply to CHIP-funded women. We've gotten guidance from CMS that says that due to their undocumented status, we do have to close their healthcare coverage following the end of the postpartum period. Obviously, that would be extended to 12 months after July 1, but our CHIP-funded pregnant women are closing during the public health emergency. And then after the PHE ends, states are required to redetermine eligibility for all enrollees and give them at least 30 days to respond to the closing notice. So we've been getting reports, people may be reporting things like I've had an increase in income, or we've had a new household member, things like that. When that's happening and we haven't been acting on that, because that would be an adverse change, we will, before we implement any kind of closing coverage, we're going to go back to all enrollees and verify that all of those changes are still correct before we make any kind of action on their case, just to make sure that if they are still eligible, and we want to make sure that information we got maybe, a year or two ago is still valid. And then depending on the end of the PHE, some enrollees may lose their MA or CHIP-funded pregnant woman coverage prior to the July 1, 2022 effective date. If this is extended into 2022, then we'll still be implementing the extension of the 12-month postpartum period amidst our temporary policies and operations during the public health emergency. Some things that we're still waiting on, CMS has stated that they'll be issuing guidance to states regarding this policy and the implementation in the near future. They've been saying that since March, so we are anxiously awaiting. CMS will soon be releasing a SPA, which is a form that Minnesota can fill out. We submit to CMS and they add it to our state Medicaid plan that shows that we are extending the postpartum period to 12 months under this option. So once that's published, Minnesota will complete it and submit to CMS for review and approval. We don't anticipate any issues or barriers with the approval from CMS. So as soon as it's released, and we know that CMS, the federal option, becomes available April 1, 2022. So we anticipate that we'll be receiving that from CMS in the next few months. And then just high level, kind of went through it quickly, but I'm happy to take any questions and do any discussion. We've talked a little bit about outreach, but if you guys have any suggestions or ideas, I'd love to hear that. So I'll stop sharing my screen. And I believe Laura has the slides and it's going to send them out afterwards if folks want them.
Great.
And it looks like I missed some comments.
Thank you so much,
Yeah.
Gina. I really appreciate this. I think what we'll want to do specific to the conversation about the Healthy Start Act is make sure we connect you with Lori and Kelly, who are working on implementation, because clearly this is going to have a big impact, and we maybe don't have time to go into questions around like what does it mean when somebody's moved into a community alternative setting and that might not be their full time. I mean, it's a time limited placement. So those are some questions I think that you'll probably want to work through together as we.
Sure, and I can give you just a high level.
Yeah.
I actually work a lot with MA for incarcerated individuals. So this is kind of like the perfect nexus of my two specialty areas here at DHS. But as you mentioned, as I think somebody mentioned before, there is a medical assistance prohibition for paying for services for somebody who's incarcerated unless they have an inpatient hospitalization. For community living circumstances, MA is available if the person has what MA calls freedom of movement. And that includes things being able to leave the facility and go to the grocery store on their own, if they're able to access doctors who are not normally available, or work jobs who are not normally available to people who are incarcerated. So depending on the level of supervision, if it's more of a tradition, I haven't connected with about the specifics of what the supervision will look like. But if they have freedom to move, then MA would cover those services. And then the children should all, I think, be at least on MA, because the children are not incarcerated. So those women should for sure be having their children enrolled on MA. And then I believe, correct me if I'm wrong, but if a woman who is incarcerated and goes to the hospital to deliver her baby, she is eligible for the payment of inpatient hospital services for labor and delivery, in which case her child is guaranteed status as an auto newborn. So her child is guaranteed MA for 1 year as well under just regular MA rules. So I'll connect definitely about some of the specifics. But that's just kind of high level MA incarceration policy.
Great. Okay, great. I just want to make sure we circle back, because this is a huge change for women to be able to access resources in the community again, and then have access to care in a very different way, which is a great thing for these young families.
Yeah, definitely a good, great move forward, I believe.
Yes. I think one of the other things, if I could just, in the last couple of minutes we have, if there's a way that we can support education and outreach about this extension, Gina, I think would be really helpful. We have home visitors that are working with families, and getting them that information, or if there's a way we, like a one pager or an infographic. I know that you'll do your formal letter, but maybe something simpler that looks less official.
Yes. Yeah, less noticey. Yes.
Yeah. Exactly. Less scary.
Yeah.
Might be something that home visitors could then bring and share with family members, or have available. I'm thinking about the clinics that that often do referrals for families to either home visiting as well. Those would be great places that we have regular contact, or that home visitors have regular contact with. I think that would be very, very helpful.
I agree. And I believe someone mentioned last time at a different meeting that we were both in, reaching out to the navigators prior to open enrollment. And we really liked that idea. And we've started, we actually have a monthly meeting with navigators at DHS. And I think we're going to bring it up at the next meeting and see what kind of training or what kind of specific, what would be the most helpful resource for them to, as they're kind of talking people through. And during the public health emergency, since we're keeping people on MA, people aren't renewing as regularly. People aren't, they haven't lost their coverage. So they don't always apply. They don't need to apply at open enrollment. But I think just kind of giving the navigator some kind of resource would also be really beneficial. So that's definitely on our radar, and we're going to bring it up at our next navigator meeting and figure out what they think would be the best resource, whether, like you said, it's a one pager, infographic, maybe it's doing some kind of modification to our basic MA, like bullet, brochure, things like that.
Great. That's great. And then if you can maybe, Gina, do one more clarification for me. I was in a meeting yesterday in Alexandria, and the question about the public health emergency, people are staying on MA, right? So if they entered MA as a pregnant individual, would the postpartum coverage be what is continued, or are they moved to general MA?
So
after the birth.
So there's actually really no difference in the benefit set between an MA pregnant woman and MA woman in the postpartum period.
Okay.
And then also there's really no difference in benefits to a woman who's, as a MA as a parent. However, being a pregnant woman does give additional benefits, like there's no copays. They're not required to complete renewals. They don't have to comply with certain like medical support rules. So pregnant women it's considered our most beneficial basis of MA. The best one you could have is MA pregnant woman. And so because we're not acting on any kind of adverse changes in circumstances, if somebody has become pregnant as determined eligible as a pregnant woman during the public health emergency, they are keeping that basis for the entirety of the public health emergency. So even if she had her baby at the end of 2020, we still have her in our system as an MA pregnant woman. And that will be until the end of the public health emergency. And in which case we'll do, like I mentioned before, we have to redetermine eligibility prior to closing coverage. So we're going to follow up and make sure she's still eligible for MA. She might move to a parent basis. If she's had a subsequent pregnancy, she might be eligible for the extension. But right now, any kind of move from MA pregnant woman to parent where they have to pay a copay and have to, comply with other requirements, we consider that an adverse change.
And then that will be the MA pregnant benefit is what will be the 12-month postpartum benefit, which is, yes. Okay, I just want to make sure I was talking about it.
Yeah,
properly.
yeah, the
Everywhere
benefits.
I go.
Yeah, no, the benefit set is the same.
Yeah.
The postpartum period is more of an eligibility construct. So they have access to the same benefits throughout the entire pregnancy and postpartum period. But it's just more of an eligibility construct of how long they're eligible for. And so they'll have access to the same set of benefits, like their prenatal months to the postpartum months, all 12.
Well, I will just tell you that there are a lot of excited home visitors because we've started going around the state talking about this, and everywhere I go, they're like, "Oh, that's really good." It just helps the MA pregnant benefit is just so much better and helps families who are just really in high need, because those copays can be, they can get in the way. So anyway, there's a lot of excited home visitors out there who want to help get the word out. So as you think about resources, we'll stay in touch and make sure we get them out to people.
Definitely. And I'm curious, like you mentioned, like an infographic or a one pager, in DHS land, we can get kind of technical. So if you if you have any specific comments about what you would like to see in there, or certain keywords that you use for family home visiting, that would be helpful. I think I would love to hear about that. If you think of things later, you can definitely email me. I'm very curious on the outreach side of things, because DHS a lot of times we're like, well, we'll send a notice. And this is something that has such a huge public benefit that I think we're interested in doing something a little bit more client friendly, a little bit more, I hate to say aggressive, but a little bit more aggressive than we would normally do. We want to reach as many people as we can. And like you said, the notices are very formal. They look like any other kind of notice you would get from DHS. So it'd be nice to do something a little bit different and kind of access women through all of the different, especially if we can leverage what you're already doing. I think that would be very helpful.
Yeah, I agree.
And I think somebody mentioned before as well, this might encourage women who are thinking of enrolling in some kind of long-term substance abuse disorder treatment. So if you can think of things like that, I think would be also really helpful, kind of encourage them. And we can think of this, how to phrase it, but say, you're guaranteed, your 9 months prenatal and now another 12 months. So if you think you need some kind of longer term treatment program, like don't hesitate to enroll in that. You're not going to be limited. You're not going to have to worry about losing your healthcare coverage. If you don't complete your renewal, it doesn't matter. You'll still have your healthcare. If you move, you're not going to lose anything unless you move out of state. But so things like that. So I really like that idea. And I think I'm going to try to mention that, maybe an infographic, just kind of encourage people to enroll in maybe longer term programs that they might not have wanted to prior to this legislation passing.
Right. And I know we are over, but
Yeah.
Kelly, you are on here, and I know you were talking about, some of the services that women are getting through corrections. I mean, this again opens a door in a way that we can really help serve these young women. And Dr. Schleifer had to jump off, it looks like, but we know that these are younger women. And if we can get them the resources they need early on, hopefully we can change that trajectory.
And really, I think the additional services like that when you're Medicaid eligible, right? Things like peer supports is a billable resource that could provide support to Healthy Start moms right before, after, and during, and or like housing supports. So when women are in our alternative placement, they could have a housing supports navigator help get them up and out of where they're at and into the next space and maybe into long-term care. So even any women or families that you're working with, if they're Medicaid eligible, depending on their living circumstance, is there someone who could support them in getting into more long-term stable housing or their own spaces, right? That's a billable service. And maybe someone could come and talk to you all about that too as a great referral. I'm not even sure the organizations to get it through, but we have been talking a lot about it for our clients because homelessness is so high.
Yeah, and I'm not in the benefits area, so I'm not familiar with the MA billable services, but that's, yeah, I didn't know that. So that's
Yeah.
really good.
It's like there's so many other things that the avenue gets opened up when you have that Medicaid service for all. So for pregnant or postpartum moms and families, that means it's a big deal. That's awesome.
Yeah, we're really excited about the rollout. So I've been working on this for several years. So it finally is like, oh, it's time. It's happening.
Great. Okay, well, thank you. I think Renelle was, you are still here, but thank you so much, Gina. As you were finishing up, as we went to Q&A, we lost about 5 or 6 people, right? At this
Sure, yeah, we're a little over, but.
So thank you. We'll make sure we get your slides out. We are happy to continue being a connector and a resource so that we just see how important these policies are together, along with some of the other that we mentioned that are in our end of session summary that are just critical for families as they get started. I cannot thank you all enough for joining us today and being such good stewards and doing such good work. We are grateful for your partnership, and we will all be in touch soon.
Thanks, Laura. Bye.
Right. Thank you.
Thanks, everybody.